Hello. I'm excited to talk with you today about Choir, our collaborative health outcomes information registry, which we're putting forward as an open source platform for measuring health outcomes on a broad basis, and then ultimately as a platform for our learning health system, one that we hope will help transform healthcare both locally, regionally, and nationally and beyond. Now, it's always worthwhile to get one's disclosures out of the way. The funding for Choir has all come from either the National Institutes of Health or through generous philanthropy. There has been no industry support for this. Our story all begins with the patient, and this is Sandra. Sandra is a young woman who I've been caring for, who has chronic pain, and has given me permission to tell her story. She's 30 years old now, but 10 years ago, when she was a young college student, in Pennsylvania, she was driving along the road when she was T-boned by a car and immediately slammed her foot on the brakes, fracturing her ankle. She ended up in the emergency department where her ankle was casted. While the ankle healed up, she was left with terrible burning neuropathic pain. This condition we call complex regional pain syndrome. And this is a photo of the type of swelling and color changes that you get with complex regional pain syndrome, or CRPS. Over 10 years, she underwent many therapies, which did not provide her with any benefit. And as can happen with this condition, she ended up with spreading of her pain from her foot and ankle on up into her arm and hand. Terrible, terrible condition, and one that's affecting many, many people in our country and beyond. When we care for somebody like Sandra, we realize that pain is not just a simple matter of finding a source of a pain generator and eliminating it, that it's not just a one-to-one link between where the injury was and where the pain is experienced. In this case, pain is incredibly complicated. And it is why we refer to it as a disease in and of its own right, much like diabetes, heart disease, asthma, and then also that it is a biopsychosocial phenomenon, one that has not only a biological basis, but also strong influences in the psychological and social domains. And if we're going to help somebody like Sandra out, we need to understand all of these components. And to date, we don't do a very good job of doing that. And that begs the question, as we segue into the real meat of this, is how do we know? How do we know if we're actually helping somebody like Sandra out? How do we know if a particular treatment that we're using for a particular patient is most appropriate? How do we know the right treatment to use for Sandra's condition? In other words, how do you go about personalizing the care for Sandra and the others who are suffering from chronic pain? And the problem with this is that the data that we rely on, these things we call randomized controlled trials, are incredibly artificial. And what I mean by that is that when people run clinical trials, and we do that, a lot of that in our lab here at Stanford, we typically screen about 100 people, and for every 100 people, we get about 10% of those, or 10 out of every 100, 1 out of every 10, that we can admit into our trial. The problem is the other 90% don't qualify. And the real challenge here is that those 90% are the people that are more representative of those we see in our clinic situations. Those are the people like Sandra. And it turns out that those 10% of people, they're very homogeneous. They're typically on no other meds other than what we may be wanting to study. They have no other medical conditions, no other pain conditions. They honestly don't look like the people that we often take care of. So we need better ways of actually capturing real-world data in real-world populations. The NIH has called for this concept of high-throughput technologies, where we can actually take large masses of data from basic science and clinical science and translate it into advanced knowledge where we can then develop safe and effective therapies. The problem is that there's been significant barriers to that translation. We run into problems in collecting data on our patients, and that there's undue patient burden, that many of the questionnaires and much of the data that we are trying to collect also end up providing significant burden on the person providing care, that we've got this mismatch between our electronic data capture systems and also the electronic medical record systems, and that much of the data is hard to compare from one group to another group. Adding to that is the problem of pain, and I'm focusing on pain here during this talk, but what I'm going to share with you is that much of what I'm talking about translates into just about every other medical condition and medical practice that we have. So I was honored to be on the Institutes of Medicine Committee on Pain, in which we put forward the document Relieving Pain in America. And what we found in this is that there's over 100 million Americans that suffer from pain, ranging from the spectrum of people who take care of pain on their own, all the way up to those who end up in tertiary referral centers, such as what we have here at Stanford. That we spend over $500 billion a year in caring for people with pain, and that is more than heart disease, cancer, and diabetes combined. It is a huge societal problem and an even bigger problem for the person who's suffering from pain. And this is the key one, that while pain can be a symptom of another condition, that when it becomes persistent, when it becomes chronic, it can become a disease in and of its own right. One like diabetes, it starts off as high blood sugar, leads to impaired glucose tolerance, and then becomes the frank disease of diabetes. And one of the first findings that we put forward in the Institute of Medicine report on pain is that we need better data. That the data that we have now that's available to understand the incidence and prevalence of pain in this country and the data on what works and for which patients needs to be dramatically improved. And so we call for here more consistent data on pain. In addition, the Institutes of Medicine has put out a multi-part series calling for the need for learning health systems. These learning health systems take patient registries, and they combine it with advanced statistical and analytical tools. They combine it with scientists, clinicians, policymakers, all of which is meant to use this data to ultimately better inform people who are caring for pain, and then to continually update that information so that we're always using the most up-to-date data, the most up-to-date information to best care for our patients. These learning health systems is what it's going to be all about. The problem is that there's been technological barriers to the implementation of these learning health systems until now. And what we've done is, in motivation from the Institute of Medicine and from the National Institutes of Health, is we've developed CHOIR, our Collaborative Health Outcomes Information Registry, which is meant as an open source, open standard, incredibly flexible and free, my favorite four-letter F word, health and treatment registry, and as a platform for a learning health system. The purpose of this is to be able to use this information at point-of-care decision-making. That means when a patient is being seen by a physician, a physical therapist, a psychologist, anybody who cares for somebody with pain, to be able to use it for comparative effectiveness research. That means to be able to compare one treatment against another treatment, as well as, by the way, cost-effectiveness research. In other words, if you have two treatments that provide the same degree of benefit, perhaps one is a lot less expensive than the other. We want it for longitudinal outcomes research, for large simple trial designs. These large simple trial designs are where we're going to be going from a research standpoint, where we're collecting data within our clinical settings. And that addresses that problem I described to you before, in which we have that, again, 10% of people typically get into our clinical trials. In large simple trial designs, we let everybody come in. We let them all come in, and we take them as they are, and we end up with a lot more noise in the data, but we're benefited by having much, much larger numbers of patients. And then ultimately, to build all this into software-based decision-making into this learning health system. And this is what we've done with CHOIR, and this is the framework for CHOIR. CHOIR sits in the middle here. We pull in data from our electronic medical record to populate scheduling information that sends out an email to a patient that tells them, go fill out a survey. We ask them to fill out a survey, and then we tie in with all of this information, clinicians, researchers, policymakers, database managers, the whole group, into a system to collect very detailed, very comprehensive data. And I'll tell you more about that momentarily. This is a blow-up of that screen that I was just showing you a moment ago with all of the players that are intermixed. As I mentioned, patients get an email reminder. If they fill that out in advance at home, that's great. At our clinic, it's about 62, 64% right now. The remainder end up filling it out in the clinic. And we collect it on every single patient that comes in to Stanford. And then the idea of this is to ultimately aggregate this information across multiple national databases into one national registry, where we can aggregate the data. We can combine the data across multiple sites to be able to draw inferences, to be able to draw conclusions about patients not only here in the San Francisco Bay Area, but out in Iowa, down in Florida, up in Alaska, because all of these patient populations are going to be different, and we need to be able to draw conclusions on what works for what patient and what condition. So we designed Choir from the ground up to be incredibly easy to use. We wanted it to be easy, particularly for the patients suffering from pain and other health conditions. We wanted it to be easy for the staff and also for clinicians. We provide this clinical workflow support that I alluded to earlier, where we send out automated email reminders. We also provide the opportunity to do data import in from the electronic medical record. Again, I want to be clear, Choir stands independent and outside of the electronic medical record, and I'll talk with you about that in just a moment as to why. And then we also provide reporting at the point of care so that the clinician can use the information right there with the patient to be able to both educate them on how they're doing, but then to use that information in both assessment as well as in making decisions on what treatments to use next. The framework of this is that it was designed from the ground up to be incredibly flexible. And we've added on additional modules into this. So for instance, we have headache modules, we have orthopedic modules, we're building GI pain modules, we're also looking at different situations such as physical therapy modules, psychology modules, all of that tying in with the main Choir system. We're using industry standard tools. Right now it runs on an Oracle backend database. We also have got this ported over to an open source database called Postgres. It uses the Java Google Web Toolkit, as well as a number of open source libraries. There's no commercial vocabularies or proprietary libraries. We leverage much of the NIH PROMIS system, as well as a computer adaptive testing. And I'll tell you about the power of PROMIS and CAT in just a moment. And then, as I mentioned before, this has been funded through a generous effort of the National Institutes of Health, as well as through the Chris Redlick Pain Research Endowment, and then also the Stanford Center for Clinical Informatics. It is, by definition, a perfect example of a public-private partnership. I get asked this question all the time. Why don't you just use your EMR of choice? Here at Stanford, it's Epic, and the short answer is you just can't do it. We tried to do this over a period of several years, and we found that most EMRs are incredibly inflexible. They're not designed to be capturing data like this. They're not designed to be as flexible as what we need, and they're not designed to be able to handle the computational demands that are required by modern patient-reported outcomes, or PROs. We decided it was much better to offload this system to a separate parallel system that links in with an EMR than to try to build it into the EMR. The other advantage of this is it allows us to be incredibly flexible, incredibly fast with our development and implementation of new features that we add into Choir. This is a typical staff view when a patient comes up to see someone in the clinic. We're able to see at a glance whether they have filled out Choir, whether they're in the process of it, or whether we need to hand them a tablet to be able to fill it out within the clinic. And as it turns out, as I mentioned before, there's about 64% right now that are filling this out at home, but the other 36% fill it out within the clinic, and we hand them a tablet, an iPad, an Android, what have you, a laptop, and they fill it out there, and it goes very, very fast. We're finding greater and greater reliance in filling this out, by the way, in smartphone technologies, and we've designed Choir so that it scales automatically for any of the devices that a patient might typically use. Now, I mentioned PROMIS, and PROMIS is worth spending a moment or two to talk about because it's an incredibly powerful system that was started over 10 years ago by the National Institutes of Health. They've invested well over $100 million into this effort. And the whole purpose of this was to recast patient-reported outcomes into ones that, as stated here, are psychometrically validated, that they're dynamic, and to be able to capture these efficiently in study populations across a wide range of chronic diseases and demographic characteristics. This was not meant specifically at all for pain. This was to measure health across the entire United States and even across the entire globe. It's based on something called item response theory, which I'll tell you a little bit momentarily. And then the kicker here again is it's absolutely free to use, particularly for non-commercial purposes. So PROMIS is meant to capture just about everything across physical, social, mental, and global health. And that's incredibly important for pain because, as I mentioned before, pain is very complicated. Pain is not just the source of nociception. Nociception are the electrochemical events that occur during injury. And so when Sandra had her ankle injury and it was having those nerves that are just firing off, pain is much more than just those firing nerves. Pain, in fact, is this complex integration, this interplay of the nociception with all sorts of cognitive factors, mood or emotional factors, contextual ones, as well as individual differences. I'm going to talk about one of these factors a little bit later and how we've used choir, one called catastrophizing. Catastrophizing is this trifecta of negative amplification of pain. It is rumination, or these repetitive thoughts that people will have about pain, and it's a sense of helplessness or loss of control of pain. So why, after having decades upon decades upon decades of standard instruments to capture physical, psychological, and social functioning, do we need yet another survey, yet another set of patient-reported outcomes? And the reason for that is, that motivated this, is there's a lot of limitations to how we've been doing this classically. The problem we find with many classical instruments are that we run into problems with both ceiling and floor effects. Ceiling and floor effects are when you get to the extremes of a range within a domain you're trying to capture. And I'm going to use physical function as an example of that in just a moment. We run into problems when people don't fill out all of the questions on those little bubble sheets if they leave a bubble unchecked, and we have to do imputation. We end up with high patient burden because they have to fill out all the questions, and many of them are proprietary instruments and they cost money. So the planned benefits of PROMIS are to be able to respond to differences across multiple treatment and patient groups, to have improved performance during those ceiling and floor situations, and to be able to compare data across these groups. And so the way this was addressed is to use item response theory and computer adaptive testing, which came out of the educational fields many years ago. So let's talk about computer adaptive testing, or CAT, and let's give you an example here. And so let's take a look at physical functioning. And physical functioning is tremendously important to capture with people who are suffering from chronic pain, because pain often takes a huge toll on their ability to physically function. And what we find is that in our center, we take care of people across a wide range of physical function. Everybody from people who are bedbound, who have been disabled from pain for many years or maybe suffering from end-of-life cancer, all the way over to the end where we take care of people who are NCAA championship athletes, and everything in between. And so if you give a person who comes into the clinic a questionnaire related to pain, related to physical function, using a classical instrument, what they'll have to do is they have to fill out all these bubble sheets that asks them question after question after question after question about physical function. And then you get a sum score. You sum all of this up, and they end up with this score here, for instance, of 73. With item response theory and computer adaptive testing, what you do is you start with a question that is in the middle of that domain. And so you might start with a question out here and ask them a question about, can they actually do walking for a period of 2 to 3 hours straight? And if they answer yes, they move up to a harder question about physical function. And if it turns out that question is that activity is too hard, it moves them down to an easier question. And using linear binary search, you can very quickly determine where that person is amongst the domain. And you can do that with a high degree of precision. The other benefit of PROMIS is that you get a comparative number. You get a PROMIS metric that you can compare against the entire United States population. And so it has a mean of 50 and it has a standard deviation of 10. That means if you have a person who on the physical functioning range is a 68, that means that they are 1.8 standard deviations above the US mean in physical functioning. And that's an incredibly powerful metric, because then we can compare somebody in the San Francisco Bay Area to somebody who is in Kansas or in Massachusetts and be able to have an understanding that the physical function that we're talking about is based on the same metrics across the entire country. So where are we with Choir? Well, we rolled this out in 2012. We very rapidly integrated this in using all sorts of handheld, tablet, PC, and other web-based devices. We learned early on to get the staff involved very quickly. They've been incredibly helpful for giving design guidance. Also, we got our patients involved quickly with helping us to understand how to best optimize these systems. We've had minimal patient or staff complaints. At this point in time, we've captured well over 5,000 unique patients. We're moving up into the 7,000 to 10,000 range, and we're now moving up into the 15,000 to 30,000 longitudinal data assessments. We've also implemented our own local computer adaptive testing engine that runs on our local server, so it's very, very fast. And the most important thing that's come out of this is that this has fundamentally changed how we take care of patients within our system. Within the Stanford Pain Management System, we are all using this outcomes-based data to help provide the most optimal care for our patients. And we use this information not only in making decisions about how to care for people, but we use it as an educational tool to show people how they are actually doing, and then to work with them to figure out which of these areas that we should be targeting the most. In talking about our system and how we've integrated it into the system, it's best to tell you just a little bit about the Stanford Pain Management Center. So we've been around now for over 25 years. We are an interdisciplinary, coordinated, comprehensive pain management program. That means we use multiple physicians, providers from different backgrounds, all working in one co-located situation. We have over 14,000 patients that come and see us on a yearly basis. We have 21 faculty, all who are boarded in pain medicine, but then also have primary boards across all of these other disciplines. We have multiple on-site pain psychologists, as well as physical therapy, nutritional services, biofeedback acupuncture. We have been a 2-time winner of the American Pain Society Center of Excellence Award, and we have incredibly strong connections between our research enterprise and our clinical enterprise. We have built an interdisciplinary platform of these services, and then layered on top of it, we've also placed a multitude of pain-specific programs such as GI pain, headache, pelvic pain, pain and addiction, orofacial pain, and yet others. And so I bring this to your attention because we have been putting this into a very complex system that involves many, many providers from different disciplines, and we found that it has worked fabulously well. What we find is that when patients come in for an initial evaluation with us, they fill out a very long history and physical examination form, a patient intake form, if you will, with the following characteristics. It takes on average about 22 minutes. The follow-up survey here is about 9 to 10 minutes. And let me show you here where we get all the efficiency. And it's all about CAT. It's all about CAT and the PROMIS instruments. In these 9 domains that we initially captured within our system, we find, after looking at thousands and thousands and thousands of patients, that on average they're filling out between 4 and 5 questions per domain, adding up to about 38 questions or so that they have to fill out. If you were instead to take legacy or classical instruments instead, they would end up filling out over 130 questions. What that translates to is about a 70% reduction in patient burden. That's a huge savings these days for patients whose lives are very, very busy, and whose time is highly valued. We want to keep this as tight as we can to be able to get the information that we can. This is the type of survey form, the reporting form that we provide our physicians, our psychologists, our physical therapists, that allows us to see in a pain diagram, which interactively the patients will check off where they're hurting, and then also longitudinally over time how they're doing across these physical, psychological, and social functioning domains. And so we've built this with the intention of turning our clinics into research environments where we can capture data from patients to use for quality improvement purposes, to optimize their care, but also for research purposes. And so we're using this now to generate preliminary data for studies, and I'll show you an example of that. Dynamic studies of pain means pain over time, system studies of pain, and then also, as I mentioned already, recording individual data for point-of-care decision-making, recording data over time, and then we'll be building into this more and more learning healthcare-based systems of pain. Let's go back to Sandra. Let's talk about her specifically. So Sandra, again, terrible burning neuropathic pain condition, has been through over 10 years of treatments before she was able to get much of any benefit. She flies out to see me on a semi-regular basis from Florida. And when Sandra first came out to see me and she filled out Choir, this is what we found, that in fact she had very high levels of anxiety, depression, and particularly fatigue, which we see very commonly in people who are suffering from pain. And she had high degrees of physical distress. In this case, these are percentiles, and higher numbers represent more negative attributes. In other words, higher numbers are worse. So what we did is I placed her on a couple different medications. I placed her on, first of all, disipramine, which is an antidepressant that we use to treat pain, and then also a novel medication that I've been studying here collaboratively for a number of years, which is low-dose naltrexone. And this is a neuroinflammatory medication that helps reduce inflammation around nerves. What we find over time is we're seeing a significant reduction in her fatigue, and then also a dramatic reduction in these emotional distress scores. We're seeing improvements in pain interference. But what you notice here, what you notice is there is no change in this green line, which is physical function. It's not budging at all. And we see that fairly frequently when we're caring for people with pain. And so what I did in this case is I got one of our health educators, Rachel Merrickett, to come in and work with Sandra on setting goal-oriented activities, things that were important for her to work on from a physical function standpoint. And what we find is that by working on those aspects, we see continued improvement across the other domains, but now also for the first time, improvement in physical function. And that's how, just in a snippet, we use Choir to help target the individual patient, individual domains that they wish to work on, and then work on that to optimize their care. We can also get a sense of how the clinic looks as a whole. How do our patients compare to somebody in another institution, in another clinic? And so these are thousands of patients within our center and compared against the entire United States population. And so you see the gray bars are the are the curves for these different domains of pain behaviors, anxiety, fatigue, depression, physical function, and the red are the patients here at the Stanford Pain Management Center. Now these are plotted with t-statistics with, again, 50 as a standard deviation. Let's try that again. 50 is the mean or average, and 10 is a standard deviation. And what you find here is that our patients have incredible amounts of disability and dysfunction across the entire physical, psychological, and social functioning domains. This is a replot of that data with now the x-axis being percentiles. And you see in particular, as you would expect, pain interference, tremendously problematic for our patients, but also many of our patients have large amounts of anxiety. Many of the patients coming in with anxiety, tremendous amounts of fatigue, depression, physical dysfunction, and other aspects of physical, psychological, and social functioning. And that's why we really need, particularly for people with complex pain problems, a team-oriented approach. We've also, with Choir, developed automated computer adaptive or computer-assisted documentation. And so Dr. Ming Cao, who is one of our faculty and has been instrumental and an incredible member of the team, has developed Choir Provider, which can pull the information from the Choir output and then develop a clinical note, typically doing about 80 to 90% of a clinical note. You can imagine he's become quite popular amongst the faculty here. So not only are we working to reduce the patient burden, but we're using things like Choir Provider to reduce the provider burden as well. I mentioned that we're using Quire for research studies. So this is the first study that will have been published using Quire. This has been done by one of our tremendous postdoctoral fellows, Drew Sturgeon, who is a research and clinical psychologist who's had a particular interest in fatigue. And what he's done is he's taken thousands of patients in our center with the Quire data and done a path analysis on it. And what we find is that all paths to physical function and pain interference seem to go through fatigue. And we intuitively know this, that fatigue has a tremendous burden on our patients, but now we're finding that many of the aspects of physical dysfunction and pain interference are all mediated through the influence on fatigue. We're also able to look at patients and investigate how they respond over time. And so we've been able to do clustering of people who are non-responders in our clinic. Yes, it is true that we have people that despite multidisciplinary care, they don't get better. If you plot them out across pain interference and physical function, over a period of time, they're not moving. And then we also find large numbers of people who are in fact responding. And what we want to see is a response means that they're moving down into this lower right-hand corner, which is what you see in this group. And we found that, in fact, the one thing that distinguishes between these responders and these non-responders is that if you can get people moving, if you can get them responding early on, that they will often continue to respond over time. Now what we're trying to do is to go back in time and to investigate these patients more carefully to find out why are these patients not getting better and what can we do to both address their unmet needs and to better optimize these care so we can turn a non-responder into a responder. We're also taking a systems approach to pain. And this has been done over a course of decades, and I'm going to use genes and gene expression as an example. And so you look at back in time with gene expression and how was this handled? Well, it was handled through gel electrophoresis, the typical northern blot that was incredibly laborious. This was then replaced by gene microarrays, which for the first time people were able to look both quantitatively as well as qualitatively at hundreds if not thousands of genes and gene expression. This was then superseded by the use of this data in one of the most famous computational biology papers of all time in 1999. Galb and Lander published this paper where they were able to do clustering of this gene expression and then characterize different types of leukemia into AML and ALL. And then finally, what we're seeing now is to use this type of information to actually dive into the inner workings of a cell and get a better sense of a systems biology view of the cells and their impact in a particular disease, in this case, psoriasis. And so we're doing the same thing with Quire, where instead we're using the patient-reported outcomes, and here that's across this row here, where each of these columns represents a particular domain, and then each of the rows here represents a single patient. And what we can do is to cluster this information into particular patterns. And we find that what you would expect is that many of the patients have what you would expect. Red represents dysfunction, if you will, that they have high amounts of pain interference, anxiety, depression, but that there are groups of patients down here that despite having high degrees of pain and pain interference and dysfunction, physical dysfunction, that they are in essence calm, happy, and they have no anger. Who are these people here? Do they represent a particularly resilient group of people that we can learn from and to help translate that information to help other patients? These are some of the questions that we're working on answering. Now, I mentioned before these barriers against translating high-throughput technologies, and I addressed this before. And this is why I think that Quire represents a real breakthrough here, a technological breakthrough in being able to provide high-throughput technologies, because we've now managed to reduce the subject and provider burden. We've addressed the issue of generalizability of the data, where it can be compared across the entire country, and we've been able to link the data from both Quire as our electronic data capture system with the electronic medical record systems. And we're using this to generate research quality clinical data in real world patients. And that's the key. To use this data for pilot data, for clinical trials, large simple trial designs, for the clinical decision making, as I alluded to before, to be able to improve quality care and the monitoring of that care, and ultimately for comparative effectiveness research as well. Let me give you one example of how we've used this for pilot data. I mentioned to you before this trifecta that we call catastrophizing: negative amplification, rumination, and a sense of helplessness. Dr. Beth Darnell, who's one of our experimental and research and clinical psychologists, has built a career understanding catastrophizing, and more recently has come up with a very novel way of treating it. It's a single session class. It's about 1.5 to 2 hours. And it's been a real breakthrough because typically the way we treat catastrophizing is with cognitive behavioral therapy that involves anywhere from 6 to 8 weeks of people coming back to our center for a couple hours at a time. That introduces tremendous burden on the patients. And so what we're looking to do is to develop brief interventions, and that's what Dr. Darnell has done. And so we used Choir to help understand whether this intervention was actually helping. And so we did this in a small pilot, and we found that, in fact, as hypothesized, Choir had a huge reduction on pain catastrophizing. Her class from catastrophizing to recovery had a huge impact on the Choir metrics of catastrophizing, of physical dysfunction, pain interference, and fatigue. And so we're now moving forward to disseminate this course more broadly. So where are we now and where are we going in the future? As I mentioned, we've developed specific modules across headache, GI pain, ortho, and we're also developing them for physical therapy, for psychology. We've developed clinical note generation, Choir Provider. We're integrating in software-based decision support. We're integrating in the information with our electronic medical record Epic, and that's through this wonderful collaboration with the University of Florida and Chris Harrell, as well as with Rob Hurley. We are also developing this concept of patient-reported outcomes on demand, where we can order up these PROs as we desire. We're working to consolidate this data across multiple sites within and outside of the specialties. We've added in yet further advanced computer adaptive testing features that we can take advantage of the clinic information to set priors on the CAT so that we can further reduce the patient burden. We've been collecting data on our patients now through something called the Stanford Gene Pool. We're working to develop integration of fitness monitors, such as the Fitbit, Jawbone, Basis, and many of these other devices. We've also developed software that allows us to do a daily sampling of this information in a handheld device. We're integrating in quantitative sensory testing, automated natural language processing, where we can take the narrative information that people provide us and be able to automatically extract relevant information for us. And then we want to develop a consumer-facing front end. And then also patient satisfaction. The patient experience is a huge, huge interest for us. We have developed a patient orientation video. This is my son, Ian Mackey here, who produced and edited, videographed this orientation video for the clinic. And we're testing this out to determine whether by viewing this up front, does it actually set appropriate expectations and help improve the patient experience later. And with regard to patient experience, we've developed an open source package called SPEC, the Stanford Patient Experience Questionnaire, which contains many of the domains, all of the domains actually, of the Press Ganey and HCAP instruments, and I'll be presenting that information in another video. So again, using Choir, we wish to use it for real-time clinical use, and our future goals here is to integrate in multiple information sources to help with longitudinal point of care reporting, clinical decision-making, ultimately triggering interventions so that if people are scoring high in a particular domain, we can recommend automatically through the software educational resources for them, as well as to provide on-demand patient education. We're integrating this into the hospital environment through perioperative Choir. We now understand that much of what a patient brings to their hospital environment, what they bring to surgery, their prior history of depression, anxiety, post-traumatic stress disorders, the medications that they're on, often have more of a bearing on what's going to happen in that hospital environment than we ever appreciated. And so we're now working to capture all that information up front so that we can then target people who may be at risk and address their particular needs. And as I mentioned, we want to aggregate in large and disparate types of information. So we want to bring in not only the patient-reported outcomes, the electronic medical record outcomes, we want to integrate in other biomarkers, other omics such as genomics, inflammatory mediators, immune mediators, the neuroimaging data, accelerometry or fitness type of data, and integrate that all into Choir. And where we ultimately want to do is then use that to develop novel therapies where we can go from the bedside to bites to bench and back again. So the future, again, for Choir is going to be through collaborations. We're expanding this to multiple clinical sites and then also outside of the pain realm. That's currently underway. We're providing the source code with minimal licensing restrictions. And in fact, in essence, it only has two. One of them says that you can't monetize or commercialize Choir. We're not into this about making a buck. We're trying to change healthcare nationally. The other is that you can't disseminate Choir, that we prefer that you send any of the code advances that you make back to us, let us integrate it into the main code source, and then release that out into the wild. We're partnering with multiple academic centers. We're working to aggregate the data on a national level. We are, as I mentioned, dependent on philanthropy to help move this forward, and so donations are very much appreciated. We have an NIH, National Institutes of Drug Abuse, training program for postdoctoral fellows. If you know of any who are interested in outcomes research, please send them our way. We do have funding to be able to pay for salary support. And as I mentioned before, the primary goal here is to change healthcare at a national level. We ultimately want to be able to make an impact on Sandra. We want to be able to improve her pain as experienced on an individual level, but we also want to improve pain at a national level and to reduce its impact on society. So I couldn't close without giving my deep appreciation and extending my thanks to all of our collaborators. These are the people that get all the work done. I want to thank the NIH Pain Consortium for all of their support. I also want to thank Chris Redlick in particular, who has believed in the vision that we've put forward in giving away this software and this platform to try to change healthcare nationally. The Stanford Center for Clinical Informatics is the group that does all the coding and all of the development, the heavy lifting, if you will. The Stanford Systems Neuroscience and Pain Lab is our lab in the pain division. Snapple, where we study the best things on earth that hurt. And then also appreciative of the wonderful collaborations at Northwestern, who oversee the PROMISE efforts, our folks at the University of Florida, other academic medical centers throughout the country. The Pediatric Pain Center here we've now worked and put this in to measure health outcomes in children who are experiencing pain, and a particular thanks to the folks at the National Institutes of Drug Abuse who have been the key leader in helping to provide support for this. I want to thank you again for your attention, for your time on this. If you wish to see more information, it can be found on this web link here. And with that, I want to close out, say thank you. And if you have ideas on ways we can improve this, on ways that we can work together in advancing Choir, and again, using this as a platform, as a learning health systems to fundamentally reshape healthcare across the nation. Thank you.